demystify a very scary topic, understandably. I think anyone hears primary brain tumor, and it's very scary. And also maybe kind of clarify where the field is moving, and obviously stress a lot of the work that still needs to be done, and a lot of the effort that's going into basic science research and clinical research, and how important that is. As was mentioned, my focus is to discuss primary brain tumors, but I'm also going to touch upon secondary brain tumors or metastases, which are much more common. Also go into the presentation and symptoms of brain tumors, the diagnosis, how do we make a pathologic diagnosis, and then what do we do from there. And in terms of treatment, because treatment is very variable dependent on which tumor we're dealing with, I'm going to focus on the two most common ones, which are meningioma and glioma. And within the glioma umbrella, I really stress and talk about glioblastoma, which I know you've all probably heard about in the news. And then kind of transition into future directions and conclusions, and of course, take any questions you may have. So to start out, primary brain tumors are tumors that are coming from the central nervous system itself, meaning there's a cell in the brain that's acting abnormally, and then it's growing out. These are unlikely to go out anywhere else in the body. Secondary tumors or metastases are ones that have spread to the brain from somewhere else, such as from a breast cancer, from a lung cancer, from melanoma. Overall, brain metastases, secondary brain tumors are much more common than primary brain tumors. The most common, as I mentioned, are the brain metastases. These account for more than 50% of brain tumors. These brain metastases occur in about 20 to 40% of all cancer patients, so it's definitely a significant issue and contributes to a lot of morbidity and mortality. And these are often spread by blood. So if you had a breast cancer or a lung cancer, if these tumor cells are able to break off into the blood, they can kind of travel up to the brain, seed themselves, get stuck somewhere, and then start growing and propagating and creating a mass. In terms of brain metastases, we're seeing increased incidence. There's a few reasons for that. Our imaging, such as our MRIs, are getting much better, so we're catching things we might not have caught on brain imaging in the past. Generally, very fortunate. Cancer patients are doing better in general in terms of survival. There's some really revolutionary treatments for melanoma and lung cancer and breast cancer, and the whole oncology field is really doing incredibly in terms of progress, in terms of treatment modalities. So the longer patients live and the better they do, the more chance that they will develop brain metastases in the long term. Further, as patients get older, as they're doing better, you have increased risk of certain cancers like lung cancer, melanoma, and thus more likely to see brain metastases associated with these. In terms of the chances of metastasis to the brain, kind of the highest chances, these are ones that are most likely to go to the brain, are melanoma, small cell lung cancer, choriocarcinoma. Ones of intermediate propensity to go to the brain include breast cancer, non-small cell, as well as renal cancer. And the ones with the low chance of going to the brain are prostate, GI, ovarian, thyroid, and lymphomas. Even though lung cancer is maybe not as high as melanoma, there's just so many patients with lung cancer. So understandably, in terms of frequency or numbers of patients we're seeing, the most common is going to be patients with lung cancer and breast cancer. Lastly would be melanoma, again with the high risk of melanoma traveling to the brain. But for the rest of the talk now, I'm going to transition to talk about primary brain tumors. Again, these are tumors that are arising from the brain itself. These are a very diverse set of tumors. I think when everyone just hears brain tumor, everyone thinks of one thing, but it's actually many, many things. And really how we classify these tumors is based on which cell it's coming from. So you have a lot of different types of cells in the brain. And normally these cells, when it's crowded, when they're next to each other, they're going to stop growing. They have signals that tell them, all right, no reason to grow or divide now, it's already crowded. For some reason, often sporadic, meaning there was no risk factor, nothing happened, but as we get older, we just get worse in terms of dividing our DNA, then one of these cells may get a mutation, and that mutation may serve like a light switch, where you're turning on the light switch, and even when it's crowded, these cells will continue to grow. And essentially, if you have a bunch of cells that have a light switch turned on, and they keep growing when it's crowded, essentially you're going to develop a tumor. And those cells are abnormal, and they can act in many different ways based on which cell they're coming from, and they can also grow faster or slower, and just change in a variety of ways. These, in general, are pretty rare. Brain tumors, I assure you, are pretty rare in terms of when we talk about cancer. It's only about 2%, especially compared to the more common problem of brain metastases, which I had talked about. So in general, very diverse group. many different types, and all of them are different. So really, all patients with brain tumors, we kind of consider them on a very individual, customized basis, okay? So kind of looking at primary brain tumors in general. On the left side, we're just looking at percentage. I'm sorry, it's a little tough to read, but the percentages we see of the primary brain tumors. In this, I'm just showing you the wide variety. You know, the biggest group is the meningiomas, which I'll talk more about. Next is kind of glioblastoma, which is a type of glioma, which again I'll kind of stress upon. But then there's a lot of other types of tumors that that are arising in the brain, such as lymphomas, germ cell tumors, pituitary tumors. You know, our pituitary gland plays a big role in terms of our endocrine function. There are pituitary adenomas, there are craniopharyngiomas, just a wide variety of types of brain tumors. And again, these are based on which cell they're arising from in the first place. On the right side, this is just kind of showing you the number of different types of gliomas. So gliomas are tumors of glial cells, and glial cells are actually not the nerve cells in the brain, they're kind of supporting cells. They play a wide variety of roles that we're learning even more about now. But their big role is playing a structural role, meaning if you didn't have glial cells in your brain just kind of be jelly. So those glial cells play a big supporting role in terms of supporting all the incredible processing that all those nerve cells are performing. But you can see on the right side, unfortunately, glioblastoma, which is the most aggressive type of glioma, is the most common we see in adults, which is sad and also very difficult, as we'll talk about more in a little bit. But again, wide variety of primary brain tumors, and even when you delve into one type of brain tumor, a glioma, a lot of different types of gliomas that act differently. And just to reiterate, meningiomas and gliomas essentially account for 2/3 of all the primary brain tumors we're seeing in adults. So that's kind of probably the largest numbers in terms of what we see in the neuro-oncology clinic. So in terms of risk factors for brain tumors, that's a question we also get a lot of from patients, understandably. Most often it's sporadic, and by that I mean there weren't any clear risk factors. There's a few genetic tumor syndromes that may contribute to developing primary brain tumors, but this is pretty rare, and that's often more common in children than in adults. The only known environmental risk factor that we're aware of is ionizing radiation. And I don't just mean like living near a plant or something like that. I'm saying if a child received radiation to their head or brain for whatever reason, for a different type of cancer, for a different illness, and they were less kind of accurate in terms of radiation doses, 30, 40 years ago, then that might be a risk factor for future brain tumors, such as meningiomas, such as gliomas. HIV specifically can contribute to immunodeficiency and increase the risk of lymphoma. And a lymphoma is a tumor of lymphocytes, and lymphocytes are the immune cells that help fight our infections and everything. But if these lymphocytes, again, have the light switch turned on and keep multiplying, they can create a tumor. That's pretty rare in the brain, but the risk is increased with HIV. And kind of, one of the big things in terms of questions we receive from patients is, what about cell phones? And so far we are not aware of any clear association between cell phone risk and brain tumors. A large study in Denmark was done. They looked at about 360,000 people who were subscribed to mobile phones over a long period up till 2007. And they found that those people who use mobile phones were not at any increased risk of developing brain tumors later. Again, when we look back to 2007, it doesn't feel like a long time ago, but at that time, not everyone had iPhones connected to their head constantly. But so far, there's no evidence or there's really no clear causation between cell phone use and brain tumors, okay? So kind of to start out, in terms of how brain tumors present, just kind of touch base upon brain anatomy, and just to kind of with the caveat, this is an incredibly simplistic representation of the brain. I think as you've heard, the brain is doing some incredible stuff. Like it's doing massive amounts of processing, maybe equivalent on like parts of the world's internet. And it's doing it on the energy of a refrigerator light bulb. If you need a computer to do the processing the brain would be doing, you need like a power plant that would be serving a city. So incredibly efficient, incredibly packed and dense with nerves and neurons that are doing all of this processing. But the brain is kind of organized functionally, meaning that certain functions are reserved to certain areas of the brain. A lot of things like memory, thinking, speech are organized across several areas, but in a kind of simplistic manner, it's organized very functionally. You can kind of see just Briefly, there's the frontal lobe. This is involved with a lot of executive functions, all the tasks that you're doing. At the back of the frontal lobe, we have there's a motor area, the motor strip, and that helps us, dictate our movements on the opposite side. So the right side of the brain will control the left, and the left side of the brain will control the right. The parietal lobe is involved with a lot of spatial reasoning and also involves some of the sensory areas in terms of sensation, again, on the opposite side of the body. The temporal lobe, which is lower down, is involved with a lot of memory. And that's kind of, again, a simplistic way to describe it, but a lot of memory processes and cognitive processes. And then lastly, the occipital lobe in the back is mostly delegated to visual processing. So you can imagine you're seeing so much, you're getting all this visual stimuli coming through your eyes and the optic nerves, and your brain is kind of putting that all together to make an image. So really dependent on where a tumor is or where you have some pathology, that's going to dictate what symptoms someone has. Kind of from a bottom view, you could see also this view includes the cerebellum, that's at the base of the brain, and that's involved with balance. So if you have a cerebellar problem or something hurting the cerebellum, then patients sometimes have a tremor or they have a walking instability. And then, lastly, another very important part is you have all these nerves kind of at the top, all these neurons, and they're sending all their axons and fibers down, kind of towards the ground. And they're all passing through this kind of major pipeline, the brainstem. And the brainstem is made up at the top, the midbrain, this bulge is the pons, and below that is the medulla. And you can see why the brainstem is so important, because not only is it dictating a lot of our breathing, our heart beating, all these things, but it's also this kind of massive cable area where all these axons are coming down, getting information from the top of the brain, okay? So generally, when you look at animals, the more advanced you get, the further and further you get development of your cortex. So the higher you go, like humans are special, is because we have so much density of neurons in the cortex, highest in the brain. And that's what's involving a lot of the thinking. And the simpler the task is, the more basic it is, it's kind of likely further down. So again, to kind of reiterate how complex the brain anatomy is, you could study this for years and still not have a complete grasp. This is kind of just a drawing of talking about what different areas are maybe contributing to certain tasks. And the thing you realize is that every single thing you do, like for instance, me picking up this cup, or me brushing my teeth, or reading something, is involving maybe hundreds, thousands of these areas at the same time. So even though one area might be dictating one task, you realize that everything you do is involving hundreds and hundreds of tasks potentially. Okay, so very complex anatomy, and even we don't fully understand all of it, but functionally organized, and that what any part you disrupt might cause a disruption of a specific task or a specific routine thing that seemed fairly easy before you had the disruption. So in terms of symptoms of brain tumors, again, depends on what area of the brain is involved. A big thing we see is headaches, but again, headaches, when you look at the global occurrence of headaches, brain tumors are a very uncommon cause of headaches. So pretty much all of the headaches seen in the clinic and with neurologist's office are not related to brain tumors. Also seizures, which I'll talk more about, weakness or sensory loss, as we talk about, especially if they involve those motor tracts or those sensory tracts, speaking trouble. Usually the dominant side of the brain, often the left side of the brain, does a lot of the work in terms of producing speech and reading and everything. So that's often a common complaint, especially if tumors are involving the left side of the brain. And also cognitive deficits. But cognition is a very diffuse process and involves a lot of different areas. So it's a little bit harder to pinpoint what specific areas was disrupted. So again, just to reiterate, headaches are an uncommon cause of headaches. So brain tumors are an uncommon cause of headaches. So a lot of people have headaches. Very unlikely it's related to a brain tumor, unfortunately. I think there are some red flags that might be more concerning, that if a patient had these, we would recommend kind of rapid evaluation. That would be if these headaches are waking someone from sleep. If someone is older and all of a sudden they have a new or different type of headache, that would be a little concerning. If the headache changes with position, for instance, if you lie down and the headache gets worse and you stand up, it gets better, that might tell us something about intracranial pressure in the brain, and that might say that something is there that's disrupting the pressure in the brain. So that would be concerning. But most importantly, if there are new neurologic symptoms, such as weakness, such as seizures, such as vision loss, that's associated with the headache, I think that's the kind of the biggest red flag, and that would be the reason to really seek evaluation pretty emergently. So, seizures that we often hear about, and I think everyone classically believes when they see someone having a seizure, they're shaking their whole body, they're losing consciousness, and that's a type of generalized seizure. At the most simplistic way, a seizure is kind of a sudden abnormal electrical activity in the brain. One analogy is that if you compared the brain to the globe, and you went out to space and you looked at America from space, you'd see lights turning off all kind of differently, but it would be pretty irregular. You wouldn't see any clear patterns necessarily from space. A seizure is essentially one state turning its lights on and off together at the same, repeatedly, and then you'd be seeing it from space blinking. And that's essentially what a seizure is, that one part of the brain is turning on and off in a very regulated manner. And that will cause any symptoms depending on where the seizure is located, where that abnormal electrical activity is located. So for instance, if it was located in the area that controls my right hand, I might get right hand jerking, twitching in my right hand. However, if it included maybe the arm and leg area, then I get shaking on maybe my whole side of the body. And understandably, if you involve the seizure of the whole brain, that's when you're going to see the whole body shaking, and then you're also going to be affected cognition, where patients are losing consciousness, maybe biting their tongue, losing control of their bladder. So you can get a wide variety of seizures, and it's all dependent on what area is disrupted. And the thing to realize is the seizure is coming from the healthy part of the brain. So if you have a tumor and it's pushing on the surrounding brain, the adjacent brain tissue, then that can cause irritation and also contribute to the seizure. It can change the electrical activity. So, after that initial symptoms, say a patient comes into the emergency room with a new neurologic issue, new headaches, new seizures, or new weakness or sensory loss, then the next step is, okay, we got to figure out what's going on. The biggest kind of tool we have, at least for diagnosis, is imaging. And this has really progressed incredibly in the past several years, that we now have ways to really get a good idea of how things look in the brain. Which has really opened our eyes and also made things sometimes more confusing. It's kind of added more confusion and more questions. The most kind of basic scan we get is a CT scan, a CAT scan, and you probably already heard about. There's a low dose of radiation with a CAT scan. A CAT scan is very quick. It's pretty fast. You're in and you're out. It's a very small dose of radiation, as I mentioned. Unfortunately, it doesn't give us a very good view of the brain. It's good for if there's acute blood, if there's new hemorrhage. It's also good for fractures or looking at bone. But for actually looking at the brain tissue, it's not as effective. I included a couple examples of CAT scans. You can see the bone is really lighting up brightly. And we see there's an abnormality here, like a tumor on this one, and same on the right side on this one. But then overall, it doesn't give us as much of the nitty-gritty of the brain itself. It doesn't tell us too much about what areas are really disrupted, how much swelling is there around a tumor, what tracts are disrupted. So the CAT scan is kind of a quick and dirty view, and that's often what we initially get in the emergency room when a patient first comes in. Kind of much more helpful for us is an MRI. That's magnetic resonance imaging. MRIs use a magnet, so there's no radiation with an MRI. With the CAT scan, it's a very low dose, but again, an MRI, no radiation. These are kind of best for tumors because it not only does it give us a good view of the brain anatomy, but it also gives us a great view of any disruption to the brain anatomy. I've included a couple examples below. These MRIs are not as good maybe for acute blood or for looking at bone, but again, for tumors and brain pathology, MRI is really what we want. It does take more time. A brain MRI can take potentially 45 minutes, and it's hard. You're sitting in this dome, in this cone. You have to sit extremely still because even a little bit of movement kind of can disrupt the imaging. But for the most part, it's very safe. Contrast is overall quite safe, except in patients who have significant kidney disease or renal failure. But overall, the contrast that helps us light up areas that are disrupted in the brain is very safe. And it's only contraindicated if you have metal in the body or if a patient has a certain type of pacemaker that might be incompatible with the MRI. But overall, MRI is really the first go-to in giving us the best view at a tumor and also the surrounding brain. After the MRI, after the imaging, and say we found a lesion, we know this is abnormal, and the question is, what is it? A lot of specific types of tumors and also metastases will have kind of distinct features on MRI. So we can tell, like, oh, this thing is bloody, or it's not bloody, or it's more discrete, or it's more infiltrative. There are different characteristics that might help point us in a certain direction and kind of telling us what a tumor might be in terms of diagnosis. Unfortunately, the gold standard, though, is to get the tissue. Getting the tissue is allowing pathology evaluation. So essentially, if a surgeon goes in, either takes out a tumor or does a biopsy, pathologists can take it on a slide, look at the slide and see, okay, what are the types of cells that are involved, which is the kind of cell, the brain cell that this tumor arose from. It can tell us, they can do a lot of stains in telling us kind of even narrowing that down further in terms of pathologic diagnosis. For most types of brain tumors, except for a few, there's some exceptions, the goal is to take out as much as you can safely. But as we talked about, the brain is organized in a very functional manner. So if you had a tumor on the left side and it's involving speech areas, then the surgeon obviously doesn't want to be too aggressive because they don't want to leave speech trouble after surgery. So the goal is kind of what we call maximal safe resection. You take out as much as you can in a safe manner that won't leave the patient with any significant deficits or morbidity after the surgery. And again, that's really dependent on where the tumor is. Patients who have tumor on the right side of the brain, especially if they're left brain dominant, again, that the speech areas are likely not to be affected. Tumors on the right side, surgeons can often be much more aggressive in terms of trying to take it all out and really resect as much as possible. Unfortunately, some tumors like gliomas are infiltrative. And by that I mean they kind of fingers and tentacles into the normal healthy brain. And if you imagine if something has fingers, you may be able to take out what you can see on an MRI, but it's likely you're not going to be able to take it all out. You're not going to be able to take out all those small cells, and you don't necessarily want the neurosurgeon digging after those few cells and potentially disrupting healthy normal brain. So that's why these tumors, especially gliomas, are infiltrative and they're much more difficult to treat than tumors that are discrete and just kind of one ball that you can just take out together. So kind of to transition, we talked about imaging of how we initially diagnosed. We talked about pathology. That's the kind of gold standard way to diagnose a tumor. And next, I'm just going to spotlight kind of the most common primary brain tumors, which include meningiomas as well as gliomas. Okay. So meningiomas, there's a few, this has happened in the news, I believe, like Maria Menounos in the news, like she had a meningioma, was fully resected. And just goes to show, all you hear is like, oh, this celebrity had a brain tumor and they were cured. And why isn't another patient or another celebrity cured if they also had a brain tumor? Meningiomas actually, they're quite common. There are probably a lot of people on the street who might have them, but they're usually benign, they're usually slow growing, and they often don't cause any symptoms. So sometimes patients will get an MRI for a completely different reason, and this small tumor might be completely irrelevant to their symptoms, but then incidentally they found a small mass. And there may often be nothing to do with that. You might just watch it because it's a single time point. If it's not causing any problems, no reason to go digging and jump in to get surgery if it's you don't want to cause more problems afterwards. But these meningiomas are growing from the sheath that covers the brain. So you have the brain tissue, and then surrounding it we have the sheath, and underneath a couple layers of the sheath is the cerebrospinal fluid. And our brain and spinal cord are constantly floating in the cerebrospinal fluid, getting nutrients, getting rid of toxins. But the dura is kind of the further outmost sheath on the brain, and meningiomas grow from this dura. So they're not coming from the brain itself, they're growing from the sheath. So they only cause symptoms if they grow large enough that they're pushing on the adjacent brain that's next to the sheath. Okay, and that's not always the case. But because they're growing from outside of the brain, they often are pretty discrete. And if they're in the right place, surgeons can often get all of it. They're not infiltrative for the most case, and surgery is often curative. And then about 80 to 85% of these are benign. And if they do grow, they're only slow growing. They're not going to spread anywhere else. And once you have surgery, you just watch. And often patients do extremely well, and that you're quote unquote in remission or cured. In a minority of patients, maybe 15%, those patients can have more aggressive types of meningiomas, atypical or anaplastic meningiomas. And in those cases, that's when we might think about additional therapies such as radiation or certain even chemotherapy drugs. But for the most part, these meningiomas are generally benign. They can be taken out surgically and often cured. Okay. And when you hear in the news that someone had a brain tumor and they were cured, it's often a meningioma. Okay. Unlike a meningioma, the gliomas, again, are not as discrete. And they're coming from these glial cells, as I mentioned, are within the brain itself. So because they're coming from the brain itself, they're infiltrative, have these fingers and tentacles, and that contributes to a lot of the difficulty in treating them, and really coming at them purely from a surgical approach. There's a lot of diversity of gliomas. I showed you that pie chart up front that there was tons of different types of gliomas, and they're all different. And they're all different within children, and more common in children versus adults. Sadly, as we talked about, one of the more common of the type of gliomas is glioblastoma, and that's the most aggressive type of glioma. That's one we often hear in the news with Joe Biden's son and Senator McCain. And this is the one we have the most trouble with, because it's a good number of patients that we unfortunately do not have extremely effective therapies yet. But we are learning so much more about these tumors every day, and that's what I'm going to transition into. And you can see on this kind of schematic, you have this tumor, unlike the meningioma, which is a discrete ball kind of pushing from the outside. This is kind of swimming from the inside. It's growing from the inside. As we talked about, the brain is doing so much incredible processing. Every single thing we do in our lives is relying on the brain. So you can imagine, you can't just go take it out. If you had a tumor in a part of your colon, you could just take out, snip, take out that part of the colon. Obviously, you can't do that with your brain without contributing to even more morbidity than what you would have before, purely from the tumor itself. So when we talk about gliomas, as I mentioned, these are tumors of glial cells. These glial cells normally do not divide and do not spread if it's crowded, but some switch turns on in them that they start turning on, and you can't turn them off, and they keep growing and dividing, and then that's when they create a tumor of glial cells, thus a glioma. Purely from a pathology standpoint, so again, this is after a patient had surgery, they send the slides to neuropathology. And neuropathology looks at it under the microscope, and first they see, okay, there's a type of glial cells. These are astrocytes or oligodendrocytes. And then they do a bunch of other evaluation. They look at atypia, which just means how much abnormality you see. Like, are the cells kind of growing in an odd way? Are they kind of all looking different? They look at mitoses, which just means that when cells are dividing, they're undergoing mitosis. So obviously, if a tumor cell is really acting abnormally and keeps dividing, you're going to have a lot more mitoses that you're seeing on a slide. Thirdly, you'll see potentially endothelial proliferation. That just means that these tumor cells are growing so aggressively that they need more blood vessels. So they start making their own blood vessels to try to feed themselves. And unfortunately, at some point, or fortunately at some point, these tumor cells kind of exhaust the nutrient supply that's there. And that's when you get necrosis, dead tissue. That from the inside, these tumors are dying because they've exhausted all the nutrients and they're not getting enough blood flow. And kind of as you would go across, necrosis is a sign that if you have necrosis, that's a much more aggressive tumor. That means that something is growing quickly, and maybe in a malignant manner, and it's growing so fast that it's exhausting the nutrients that are there. And this is how, we get a grade. This is how they were graded, that if you had a grade 4, a glioblastoma, that means on pathology, the neuropathologist kind of checked all these boxes, that there was weird looking cells, there was a lot of dividing cells that were proliferating, there were cells, there was increased blood vessels that were being created, and lastly, that there's potentially necrosis, there was dead tissue. And all of those check marks, if they were checked, then that would be glioblastoma. And before we would be like, okay, we would presume prognosis and treatment all just based on the grade. But the thing is that even in the past 5 years, we've learned so much more about these gliomas, and we realized that, grade is not as important. A grade 4 doesn't necessarily act worse than a grade 2, and vice versa. Before we used to always think, if you're grade 2, it's a low grade, you don't have to worry about it, or if you're grade 4, it's so horrible. But that's when we found that with the genetics of the tumor, identifying what is turning on that light switch is really helping us get a profile of patients and understanding what they're more likely to respond to and potentially how they're going to do with treatment. And just kind of a quick overview, and just, I'm not going to delve too much into this because a lot of it's a little deeper science, more complicated. But this is kind of, just in recent years, we found that, gliomas up front, again, the grade didn't matter as much as the genetics of the tumor. And by genetics, I don't mean the genetics of a person. This is not something that's passed on to them or that they're passing on to anyone else. I'm talking about the genetics of the tumor. What are the mutations in the tumor tissue? What are those light switches that turned on that made these cells grow in the first place? And they found that, there were a few key mutations. So in a sense, if a patient's tumor had this IDH mutation, they were already in a better group. those patients with an IDH mutation were already probably responding better to treatment, living longer, and that was regardless of whether they were grade 2, grade 3, grade 4. And similarly, if the patients had an IDH mutation, they would take it one step further. If they had this 1p19q, this purple mutation up on the top, then that put them even a better group. So those patients who had both the IDH mutation and the 1p19q, those are the patients who do the best, regardless of their grade initially. Those are the patients that respond best to treatment, and often many of them are living for long periods of time. And that's because on the right side, you could see having these mutations, both in this IDH and this 1p19q, contributes to other mutations in the genetics of the tumor that both contribute to this tumor growing and maybe tell us why these tumors are more responsive to treatment such as radiation and chemotherapy. Similarly, on the opposite side, if you had the IDH mutation without the 1p19q, those are the patients with gliomas who kind of did moderately. They were in the middle group. They didn't do as well as the patients with the 1p19q up top, but they do better than the ones who don't have the IDH in the first place. So essentially, I'm just bringing this up to show that we kind of split conceptually these gliomas into 3 groups, at least the adult gliomas. Like, do they have an IDH mutation? If they do they have the 1p19q? And if they don't have the IDH mutation, unfortunately, that means that regardless if they're grade 2, grade 3, grade 4, they're often acting like a glioblastoma, even if they weren't called a glioblastoma based on the histology. And this is just, I'm not going to go too far into this, but now this is in the new WHO criteria. They went through it and they realized that, okay, the histology is not enough. Just looking at the slide is not enough. And they've started integrating all of these molecular genetics of the tumor into the pathology diagnosis. And kind of one example is, it doesn't matter if something is an astrocytoma or oligoastrocytoma or oligodendroglioma based on the histology, based on what the pathologist is seeing under the slide. If they have an IDH mutation and they have a 1p19q codeletion, they're this oligodendroglioma, regardless of what was seen up front. So now we create our groups with both the histology and the tumor genetics taken together. And that's kind of revolutionized all of cancer and has been really helpful for us in terms of deciding treatment and also determining prognosis. That's a kind of, people say it's like glioblastoma is not a glioblastoma, is not a glioblastoma. Every patient is different. Every tumor is different based on their tumor genetics. Similarly, as in the old days, I'm saying even like 10 years ago, when we talk about prognosis, it will be based on some factors like, is the patient older? Do they have a larger tumor? Do they have neurologic symptoms? And we presume that if they had these, then the prognosis is worse. And now this is kind of flipped on its head once we've learned about these tumor genetics. And now, this is just I'm not going to get too bogged down in this, but just to show you, on this axis is the years that people are living, and this is the percent that are living. And you can just see there's this group out here. There's a percentage of maybe 30 to 40 patients out here that are living 15 years out, which you would never have heard of. And they found that that's all related to those mutations. It doesn't matter as much the grade. And you can see, unfortunately, on the other end, which is the end that we're really trying to focus on and we need better treatments for, is that it didn't really matter if a tumor was low grade or if it was called GBM or if it was called a high grade glioma. If they didn't have an IDH mutation, if it didn't have those positive tumor genetics, it didn't make a difference of the grade, and those patients did poorly and unfortunately can pass away quickly as well. So this is kind of telling us that we need to integrate the tumor genetics, both for making diagnosis but also for determining prognosis. So in terms of kind of general schematic of glioma treatment, again, I'm going to focus more on glioblastoma in a second. This is a really interdisciplinary disease. And by that I mean, so we have, at the Brain Tumor Center, it's a very cooperative and very close work of several physicians. So, you have a fantastic tumor neurosurgeon who does his or her best to take out as much of the tumor as safely possible without leaving the patient with any significant deficits or new problems. That helps because, number one, we can make a diagnosis, but also potentially relieves the pressure that the tumor was putting on the adjacent brain, maybe decreases the risk of seizures, can improve patients' weakness or speech trouble. So the surgery is both therapeutic and also diagnostic. Next, a big part of glioma treatment is radiation. And that's kind of under the purview of a radiation oncologist. And the radiation oncologist works with a nuclear physicist in terms of determining where to deliver radiation. And when I say radiation to the brain, I don't mean the whole brain. It's not whole brain radiation, which we use in certain cases, mostly potentially with patients with a lot of brain metastases in multiple parts of the brain. For glioma, we're talking about to just the area of the tumor. And as I talked about before, these tumors have fingers in the normal brain. The surgeon, no matter what, even if they take out as much as they can see on the MRI only has certain resolution. You need to have like millions of cells together before you potentially see it on an MRI. And we know that even if the surgeon says, I took out the gross total resection, we're pretty confident that because of the fingers, there's probably some tumor cells left in that cavity. And they have the potential to grow and keep dividing. So that's why the radiation is kind of this non-invasive way to kind of kill those residual cells in the cavity, okay? These are usually given, radiation is given over several weeks. The goal is you want to split the radiation into a lot of small pieces in that you're delivering enough radiation with each fraction that you're killing the tumor cells, which are likely more responsive to radiation, but not too much radiation that could hurt the normal healthy cells. That it's like a quick balance. It's a very delicate balance because if you give too much, then those normal brain cells may not be able to recover, but if you don't give enough, then those tumor cells may not die. So that's why it's fractionated, meaning it's cut into multiple fractions over several weeks. And generally when we talk about radiation, patients come in, they're usually in and out. There's a 1 to 2 week planning process where the radiation oncologist does that mapping on the MRI, but they also make a mask to keep a patient's head still. But when they come for the radiation itself, patients don't feel it. The main side effect is fatigue, especially on the latter course, the latter half of the radiation. But overall, you're not going to feel any specific symptoms other than potentially hair loss. And then the next question is, chemotherapy, and that's when, that's my role in this interdisciplinary team in terms of deciding which is the best chemotherapy drug for this specific type of tumor and for this specific patient. Because if a patient's older or has other medical comorbidities, chemotherapy can be toxic as well. So it's really a kind of customized approach, both in terms of how much surgery or what's the extent of resection, in terms of how much radiation or how long the course is, and also in terms of which drugs we administer to further both the hopes of the chemotherapy is that it's going to improve the strength of the radiation and also alone potentially kill tumor cells. But for a lot of gliomas, really surgery and radiation are the most important part, okay, especially in the cases of glioblastoma. So kind of, to transition, I kind of talked about this umbrella term of gliomas. I talked about those 3 groups of gliomas and, told you that based on the tumor genetics, we can really kind of prognosticate and know which are the gliomas that are most likely to behave the worst, to be the most aggressive. And again, as I'm using it kind of in general as glioblastoma, but then these are those patients who don't have this IDH mutation in their tumor. These are the patients that it doesn't matter if it's grade 2 or if it's grade 4. They're potentially not going to do well. As I mentioned earlier, the glioblastoma these are the most aggressive type of gliomas. It's a very horrible, malignant, fast-growing tumors. And because it's in the brain, it's kind of growing in and between the nerve cells. These glial cells have some mutations and they keep spreading and growing, and they're kind of spreading in between and disrupting all the nerves in their wake. These generally don't go anywhere else in the body. In rare circumstances, they can kind of go down to the spinal cord because the brain and spinal cord are all part of the central nervous system. But it's pretty uncommon. But the main issue is that it can spread to other parts of the brain. And that's the concern, that is all you need is one residual cell to start kind of acting up again after treatment and make the prior treatment kind of ineffective. Unfortunately, we don't have a cure for glioblastoma. And this is a big kind of focus around the country, around the world, because even though we're having some incredible new treatments, much more effective in other types of tumors like melanoma, lung cancer, breast cancer, glioblastoma is still quite poor, and we're learning a lot more about how these tumors act, about their tumor genetics, but the treatments are still wanting. And that's why even a big part of the cancer moonshot that Joe Biden announced, a big part is also kind of put a focus on glioblastoma. And that's why so much of cancer research and is kind of potentially going into trying to figure out more the understanding these tumors at a basic science level and transitioning that to the clinical trials in terms of finding better therapies, which is obviously our ultimate goal. But sadly, we're still limited, and we are not still able to do enough for a lot of patients. So I'll get more into that. Unfortunately, a lot of glioblastomas are presenting in older patients. And usually if it comes in older patients, it probably wasn't there for a long time. It probably just came on and then progressed very quickly, potentially over the span of months. As you can understand, anyone who's older has other medical comorbidities. They potentially do worse in terms of outcomes compared to a younger patient who's healthier and doesn't have other medical problems. So in terms of glioblastoma treatment, similar to the other gliomas that I mentioned, first you go for maximal safe surgery. As I mentioned, even if there's a total resection of what you can see regarding the tumor on the MRI, there's still likely residual tumor cells at the edge of the cavity that still need to be addressed. And then that's when the radiation comes into play. Again, this is administered over several weeks. You're delivering small fractions of radiation, likely over 6 weeks. And the goal is to kind of kill those tumor cells that are still surviving the surgery, okay, that were not taken out. And then the chemotherapy, our standard chemotherapy is temozolomide. The brand name is Temodar, okay, and we know this chemotherapy gets into the brain pretty well. That's a big problem in terms of gliomas or brain tumors in general. And part of the reason why they're so hard to treat is that, the brain, I talked to you about that dura, that kind of sheath, that kind of protects the brain, but there's also this blood-brain barrier, meaning this barrier that separates the brain from the arteries that feed the brain. And as you can imagine, there's a lot of positive aspects to this. Every time you get sick, the toxins don't go straight into your brain, and all of a sudden you're confused every time you have the flu. There's protection there. And that barrier it's a wall and has doors only for certain things. Only certain things can get through. Usually that's a good thing, because you don't want most things to get into the brain. Unfortunately, though, chemotherapies, many of the ones that are used for systemic cancers, are not getting into the brain. So even if you potentially had a chemotherapy that would work, if a tumor is in the brain and the chemotherapy can't get in, it doesn't make a difference, and then you're just introducing toxicity. And that's part of the reason why these tumors are so difficult to treat. But the standard chemotherapy drug is Temodar, and that's an oral chemotherapy. It's taken on an empty stomach every day during radiation initially, and the goal is that it's going to sensitize the tumor towards the radiation and contribute to the tumor cell killing. Okay, and we know that based on the genetics of based on the genetics of the tumors, certain tumors are more likely to respond to chemotherapy. So we have even a better idea now, based on the pathology genetics, of saying this patient's glioblastoma is more likely to respond to the Temodar, and this patient's more likely to do well on the chemotherapy and likely will live longer. So it's helping us prognosticate and also predict. After radiation is done, generally speaking, it's a month. We give patients a month off, and they recuperate, they get their strength back. And then the next part of the standard treatment is to restart the chemotherapy on a different schedule. But then usually radiation is a one-time thing for the most part. Unfortunately, this standard treatment, there are some patients who can do very well with standard treatment. Some patients finish a whole year of additional chemotherapy, and then we just monitor with scans. But unfortunately, on the other side, there are some patients who they progress even potentially during radiation, potentially right after radiation, or potentially in that post-radiation chemotherapy period. And that's why we're following pretty closely with MRIs at least every 2 to 3 months to catch any tumor regrowth, especially if it's before the patient would have experience any new symptoms. Unfortunately, glioblastomas pretty much always recur. There's a few cases that patients are living far out, but they are the minority. And this just kind of lends to crucial need for better treatments and more resources going into cancer research, especially within glioblastoma. As I mentioned, we know that some patients respond better to chemotherapy based on the tumor genetics. Now, for pretty much any glioblastoma that comes through, we both do it in-house and send it out for extended genetic profiling. And again, that's genetics of the tumor, not of the patient. And that's to identify those mutations that are causative, that cause the tumor to grow in the first place. And the goal is that maybe we can target some of those mutations. If that's the mutation that caused it to grow, if we stop that pathway, maybe the tumor will stop growing. The hard part about glioblastoma compared to other cancers is that not only are some of the drugs not getting into the brain, but they found that even when they look at these tumor cells under a microscope, they're kind of different from each other, even next to each other. So you could have neighboring tumor cells in a group of millions of cells, and all of them are different. So if you imagine, it's like playing whack-a-mole, because it's like I know that there's maybe this mutation, but I don't know that all of the cells have this mutation. So it doesn't help to kill only half of the cells. It's like all or nothing, because even if you have one surviving cell, it can start reproducing and cause the spread of a tumor. So that's the hard part about glioblastoma. It's so heterogeneous. There's a lot of genetic heterogeneity that all these cells are so unique from each other. and that makes them much harder to treat. So thus, on progression, if patients have done the standard treatment or in the middle of the chemotherapy after radiation, they have progression, then the first thing we want to look for is clinical trials. And that's a big thing, and that's a huge focus in neuro-oncology in general, both in terms of identifying both safe and effective agents. And a lot of that's based on basic scientists that a lot of phenomenal scientists around the world are doing, and doing drugs and experiments both in the lab with animals, and then kind of bringing that to the clinical side to see if they're going to work in people. And that's a big jump, because things can work in the dish and can work with mice, but then they don't work in the brain, in the human brain. And as you can imagine, that's, as I talked about, our brain is just really unique. It's doing some incredibly a massive amount of processing with very low energy. And the environment of these tumors in the brain is probably very different than what we see potentially in the petri dish or even in another animal. So another big part of the basic science is figuring out better models for these glioblastomas, better models in animals, and also better models in the preclinical side and the in vitro side as well. If clinical trials are not an option, and sometimes they're not, because if you could imagine, you don't want to give something experimental that we don't know if it works or not to someone who has a bad functional status, who's already having some significant weakness or significant speech trouble, or if they can't walk, then those folks are probably at increased risk of developing side effects from any experimental treatment. So if that's the case, then we consider other agents such as bevacizumab. You might have heard about it. The brand name is Avastin. This is not a chemotherapy per se, it's an anti-angiogenic agent, and that just means it kind of blocks the blood vessels that feeds the tumor. The goal is that it starves the blood flow from the tumor. And most gliomas most glioblastomas respond to Avastin, at least on the MRI. The question is how long. Some patients potentially can go further out and continue to respond after 6 months, but then unfortunately also a lot of patients after 3 months they stop responding. So initially they had some shrinkage of the tumor, and then the tumor kind of grows through it. So Avastin is improved. It's FDA approved for recurrent glioblastoma, but we found that that's definitely not the magic bullet that we need for this type of tumor. And again, as I mentioned, we send that genetic profile on every glioblastoma, and we hope to, now the drug companies are developing, and a lot of academic centers are developing all these drugs targeting mutations. And so if we have a mutation and we have a drug that targets it, and we think the drug gets into the brain, then it might be a good candidate. Again, with the caveat that we don't know if all of the cells in this glioblastoma tumor have that mutation. All right. Unfortunately, the median survival for a glioblastoma is 15 months, and that's a really sad figure, and it's sad also because it hasn't changed much over 20, 30 years. But again, this is kind of going back to, this is everybody, but going back to those 3 groups of gliomas I created, based on the genetics, there are patients who maybe were initially called glioblastoma, were potentially living 10, 15 years based on the tumor genetics. Conversely, that also means that there were sometimes low-grade, quote-unquote, low-grade tumors that were grade 2s that didn't have this IDH mutation that potentially are passing away quickly as well. So this is a median, so it's not one person, and no patient is an average. Every patient is different. And that kind of transitions me into our conclusions. That tumor genetics is extremely important. As I mentioned, both not just in glioblastoma and gliomas, but a lot of type of brain tumors, we're getting those tumor genetics, trying to figure out what are those switches that are being turned on that cause these tumors to grow in the first place. Every patient and every tumor is different. You might hear of why is someone in the news as I mentioned, someone was cured after a brain tumor. If they had a meningioma, that's very reasonable, and there are a lot of other types of potentially brain tumors that are easily resectable and that patients will do well and don't need any additional radiation or chemotherapy. But as I mentioned, even within the realm of gliomas, there's a lot of changes, a lot of variety, and a lot of diversity of pathology, and a lot of every tumor is unique and maybe behaves differently with treatment. Immunotherapy, we're really excited about in the cancer community. So far, a lot of the drugs that you might have heard about, like Keytruda and Opdivo, which are pembrolizumab and nivolumab, these are drugs that kind of increase the body's own immune system response to tumors. And there's been some incredible responses in certain types of tumors, like melanoma, certain types of lung cancer, renal cancer, bladder cancer. Unfortunately, for so far, in brain tumors and gliomas, they haven't been that exciting. And there's several reasons for this. Probably foremost is that these glioblastomas are really good at cloaking themselves. The immune system can only go after a tumor if it sees it, or if it smells the blood in the water, then it can go chasing after the tumor. Unfortunately, glioblastoma is very good at cloaking itself. It hides itself, so the immune system can't see it. So it doesn't matter if you give this immune therapy to boost the immune system, because the immune system doesn't know what to chase after. So that's part of the reason that immunotherapy is maybe not as effective in gliomas, at least based on preliminary clinical trial data. Also, as I talked about these switches, these mutations, they found that the more mutations you have, if you have 20, 30 mutations, you're more likely to respond to immunotherapy, because the immune system is likely able to see it, because those mutations probably cause this tumor to quote-unquote bleed a little bit more, and it's able to smell those antigens and chase after it. Unfortunately, glioblastoma compared to melanoma has less number of mutations. It's not as mutagenic as some of those other tumors that do respond to immunotherapy. But that's not to say, that maybe immunotherapy alone is not sufficient, but maybe you need to do something else in addition to immunotherapy at the same time. Maybe you need to deliver radiation to make this tumor bleed, to make the immune system see it, so it can chase after the tumor. And so right now, a lot of the trials and a lot of the science research is going after what are ways we can boost the efficacy of immunotherapy in brain tumors, because so far it seems like it's not as good alone. Can't stress this enough, the clinical trials and the basic science research especially is incredibly important, just because, as I mentioned, that figure, 15 months, that hasn't improved much, even over 30 years. That's really sad, and we're not doing enough for these patients who probably have the most need and are going through this, patients and their family members. So I think we have a lot of work to do, both on the basic science side, to learn more about these tumors, why are they being created, what are the risk factors maybe that we're not aware of yet, and then also how are we going to treat them, what are treatments that are safe, that are getting into the brain, and that can kind of overcome some of these obstacles that we're dealing with this tumor, which is kind of just incredibly efficient, and it's kind of like a monster that's very hard to deal with, and it's a very strong monster that adapts. And if you have something that's adapting, you need to have potential treatments that can have efficacy even when something is changing, and I think that's really hard. So lastly, conclusions. Lots of different types of brain tumors. Meningioma is not a glioma, and even within glioma, there's tons of different types of gliomas, and even within glioblastoma, the genetics kind of can tell us a lot and kind of separate patients based on how they're going to respond to treatment and how well they're going to do. Each patient requires unique and a customized regimen, and that it may include one or all of surgery, radiation, and chemotherapy, and other drugs. Genetic profiling of these tumors is really helping us customize the treatment, because we're able to hopefully identify these mutations, identify these light switches, and then try to target them. Because of this genetic heterogeneity of patients, every patient is different, and there's a lot of stuff online that's incredibly scary. And a lot of it's informative, but a lot of it is maybe not relevant to one patient. And you can imagine, as anyone would, for your loved one, you want to scour the internet and find everything that's going on. But sadly, there's some misinformation, and also there's a lot of information that's just not directly relevant to a single patient. And that's something to remember, especially when we hear something in the news about Senator McCain, or Joe Biden's son, or another a celebrity who had a meningioma. We don't know the full story. We don't know where the tumor is, like what's the extent of their surgery they were able to undergo, what was the pathology, what was the tumor genetics, and what other kind of complicating factors are there. So it's really hard to make any generalizations, especially when we hear about things in the media. And lastly, I can't reiterate it enough. In terms of Brain Tumor Awareness Month, we need to be better, and there's a lot of incredible scientists and trial researchers around the globe who are really trying to put a massive focus into these tumors, because, as I mentioned, some of them are still pretty ugly, and they're angry, and they can be horrible for our patients, and we still have a lot of ways to go in terms of helping more of these folks. Okay. So with that, I thank you all for coming. Really appreciate you listening, and please let me know if you have any other questions.